Dr. Smink is going to come up, and Dr. Smink love Dr. Smink. She's on the Sickle Cell Council. By the way, she is a board member for the Sickle Cell Council. She is one of our board members. She's been on our board since 2021. I don't remember the month. I want to say it was May, but definitely 2021. And she's definitely the things that she'll explain the things that she does. I don't need to say another word. Dr. Smink, please join us. Thank you.
Thank you for having me. So I'm Gayle Smink. I'm one of the pediatric hematologists and director of the pediatric sickle cell program, and recently the director of the adult sickle cell program as well. So I just have a couple slides. I know that there is a variety of people's experiences in the audience, and I thought it'd be really helpful to talk a little bit about sickle cell disease. As far as, I love that Pfizer video. It's actually one of my favorite videos, and we use it often because I think it's a great way to explain to people that may not have a lot of understanding about sickle cell disease what sickle cell disease is, what happens in the setting of patients that have sickle cell disease and families caring for individuals with sickle cell disease, to have a better understanding of kind of what is happening, even though they may not see it on the outside. So, and I also want to talk a little bit about transition. So I think one of the most important things as a pediatric hematologist is talking about transition. I appreciate Ron, and we run into each other a lot at events because I really am so thankful that we now have a whole generation of adults living well into adulthood with sickle cell disease. And there is a huge need that we have to take care of patients and families with sickle cell disease. And I think the South Central Sickle Cell Council has a huge role in helping to ensure that individuals are getting the care that they need. Next slide. So I just am going to talk really briefly about kind of how common sickle cell disease is. For many people, it feels rare, but it's actually a very common medical diagnosis that we take care of. And many children that I take care of as a pediatric hematologist are living into adulthood, which is wonderful. But how do we provide the care that they need? We're also going to talk a little bit about kind of what happens in sickle cell. Now, sickle cell disease. Now, I think that video actually does a way better job than I'm going to do. But I think talking through why things happen and what the results are of that pathophysiology inside the body is important. And I'm going to talk a little bit about our transition program, which has drastically changed since September of 2024. And our teams at Penn State Health have changed over the last 6 months. And I want to recognize some individuals that you're going to start to recognize at events and be a part of the sickle cell care team, which are really important as we move forward. Next slide. So sickle cell disease is the most common. Can I actually take this off? Sorry, I move around a lot, and I'm also loud, so I totally probably could do this without a mic. But so sickle cell disease is the most common diagnosis on newborn screen. So majority of individuals across the United States and US territories are diagnosed on newborn screen. So what does that mean? We do universal screening for certain diseases, including sickle cell disease, so we can diagnose sickle cell disease in infancy. So it is now, for the last about 20 years, since now I guess it's 2025. So 20 years, we have done universal newborn screening in every baby born in the United States and across all US territories for sickle cell disease. So they're identified in infancy. That's not necessarily the case if you're born outside the United States. So individuals that are immigrating to the US may get a diagnosis of sickle cell disease when they come to the United States. And so that is one thing to be aware of, that there may be individuals living in our community that immigrated to the US that don't even know that they or their children have sickle cell disease. It affects about 100,000 individuals in the US. So sickle cell trait is a very common genetic abnormality that we see in the general population. It's about 1 in 12 African Americans that have sickle cell trait and about 1 in 35 Hispanic individuals. And if you have 2 individuals that have sickle cell trait, they have a 25% chance of having a child with sickle cell disease. One of the things that I think is the hardest from a public health standpoint is to realize that it's not just hemoglobin S, it's actually other abnormalities in the hemoglobin molecule. And so many people think about sickle cell trait as far as sickle cell S gene mutation, but there's actually other mutations that can cause sickle cell disease. Over the last 50 years, there's been a significant increase in life expectancy in sickle cell disease. Some of that is because of universal newborn screening, the initiation of penicillin. So anyone who's had children or no children that have sickle cell disease, they are started on penicillin in infancy, and then improve vaccinations. Now, unfortunately, the life expectancy has really plateaued recently. And part of that is because, like Ron was talking about, is the care that adults are able to receive as they move through their life with sickle cell disease. Next slide. So what happens in the setting of sickle cell disease? So red blood cells are responsible for bringing oxygen to all of your tissue, and that oxygen is used to make energy. So it's really vital for every cell to get oxygen. In the setting of sickle cell disease, there's an abnormality in the hemoglobin molecule, which is what carries the oxygen through the body. And that hemoglobin molecule can get distorted and stick together, and that's what changes the shape of the cell from more of a disc shape to a sickled shape. And that sickled red blood cell is now very fragile, so it doesn't live as long. It also is very sticky. It sticks to the blood vessels and causes vaso-occlusion. Next slide. Thank you. And that single point mutation results in all of these changes to the red blood cell. Now, what I try to impress upon families is that even though patients are well, there's still sickling happening inside their body. So you may not see it, they may not feel it, but it's happening. And we know that because individuals that have sickle cell disease develop complications, organ complications as they age. And we know that because there's sickling happening in those organs, including their kidneys, their brain, their lungs. Next slide. And so those red blood cells that are all stuck together now cause an occlusion of the red blood cell, or the vessel, and then once that opens up, it actually causes what's called a reperfusion injury. So there's several mechanisms of action of why sickle cell disease leads to the common complications that you see. Next slide. And so I like to put this picture up because sickle cell complications happen from the top of the head to the bottom, to the soles of the feet. And so individuals living with sickle cell disease are warriors because they are constantly having to manage complications of their sickle cell disease that present in a varied way depending on the patient. So every kid that we take care of and every adult has different types of complications from their sickle cell disease. Next slide. And I bring this up again because as the survival of sickle cell disease has been prolonged, and most of our children, more than 95% of our children are living into adulthood, we have to talk about how we best care for adults living with sickle cell disease. Next slide. And so what is transitioning? Transitioning is really how do we transition patients in a planned and purposeful way from pediatric care into adult care. Now, I will say there are certain areas where there is excellent pediatric care in a paucity of adult care. And so there's many settings where individuals living with sickle cell disease don't have a hematologist that they can find in their area. And so how do we make transition successful? So we do that by engaging a multidisciplinary team. We collaborate with all those members of that team, as well as the patient and the family, to start that transition process as early as 12. So we start talking about how do you care for yourself? How do we equip you to be successful when you age out of a pediatric program and are starting to be cared for in an adult setting? And that process is different for every family. So transition goals are always going to be how do we continue medical care across the lifespan that's uninterrupted, that's patient-centered, that's purposeful, that's flexible and comprehensive. So how do we do this from a pediatric standpoint? So we use a lot of tools to help us with transition. There are lots of ways in which we assess patients' readiness for transition. And we start as early as 12 talking about what that means when they turn 18 or 19 or 20. We're fortunate that most of our pediatric patients have a very engaged family, and that family has been very engaged throughout their entire life. And so they are helpful in that transition process. But there is a significant risk of children and adolescents moving into young adulthood with sickle cell disease. So the reason I bring this up is the mortality rate, when you look at individuals living with sickle cell disease, increases substantially once they hit 20. And some of that is they're now venturing out on their own. They may be living independently. They're really assuming much of their health care, and that can be very challenging. And so there's more than twice the risk that they'll have a major complication in their early 20s, even in individuals who've had very minimal complications from their sickle cell disease up to that point. So transitioning and preparing individuals for transition is a really important part of the process. So how do we prepare individuals in adolescents and young adults for transition? We utilize transition tools to help assess where they are at in that developmental process. We start the discussion early, and we really start to encourage adolescents to start taking some ownership over their own health care. Can they call in their own medication refill with the assistance of their parent? Can they schedule their appointment when they check out? So how do we start to give them some tools to be able to care for themselves once they're adults? And so what are we doing here at Penn State? So we've been fortunate that for many decades, we've had a pretty robust pediatric sickle cell program. I've been part of that program for about 9 years. But the adult program we did not have one until about 2021. And we're fortunate that Matt Evans, one of our previous adult hematologists, had a specific interest in forming a clinic that helped to address the needs of individuals living with sickle cell disease. And we are now growing that clinic in a couple different ways, including hiring Nikki Diallo, that I would like to recognize today, as our adult sickle cell nurse practitioner, who will be the face of our adult sickle cell program, along with Michelle Day, who's helped in this transition. And myself. So we had a pretty separate adult and pediatric program up until September. Now we're having a much more comprehensive overlapping lifespan program where I actually go to adult sickle cell clinic, which I will say has been an absolute joy because I took care of many of these patients and families for a long time, and then they transitioned to adults and I don't get to see them anymore. And anyone that, has a pediatrician knows that we have a really hard time with that process. And we're really terrible at it because we don't want to give up our families that we've been caring for so long. So I'll be seeing young adults in adult sickle cell clinic. Nikki will be coming and seeing adolescents as we start to transition in our pediatric clinic. So there will be several years of overlap. We also now have a dedicated nurse coordinator on both the pediatric and adult side that help to coordinate care of appointments as individuals are transitioning. So we're talking about that age between 15 and 25 especially. And then our hope is to grow our adult sickle cell program to help individuals living with sickle cell disease have more options for treatments, including curative therapies like gene therapy. So these are our names. These are the people that are on our teams. We have, like I said, now more of a comprehensive lifespan program for our adolescents, young adults living with sickle cell disease, and hope to continue to expand our adult resources with the help of the South Central Sickle Cell Council, which I think is really vital in providing community-based support for families and individuals living with sickle cell disease. And I'd be happy to take any questions or answer questions afterwards if people have any.
Thank you so much, Dr. Smink. Appreciate your assistance, your service, and your sacrifice, even as a part of the things that you do on the volunteer side of the sickle cell. Thank you.